So we will be covering a lot of topics today, and we will be covering respiration and pulmo, and we will be covering around 14 topics. And it's not really image ready. I'm gonna download and put image. So let's start with the contents. We're gonna study first in this video. We're gonna cover neonatology, then we're gonna go for obstructive, then we're gonna see for genetic problems, restrictive, and then the infection itself, and then we have trauma. So we're gonna cover 6 topics. So let's start with neonatal and congenital airway problems. Okay, so neonatal and congenital airway problems. So the first 4 topics that we're going to talk about is TEF, that is transesophageal fistula, choanal atresia, CDH, and NRDS, right? So it's just congenital, simple stuff. We're going to talk one by one. These are the photos. We're going to come back to them. So first thing we're going to talk is about atresia and fistula. 2 things, okay? So whenever we are trying to understand these 4 problems in children, in neonates, we want to ask simple questions. We want to ask, can the baby swallow? Can the baby breathe through the nose? Are the bowel loops in the chest? And was the baby premature? So that's the 4 questions you want to ask. These 4 sets of questions will immediately separate these 4 topics. That is fistula, atresia, CDH, and NRDS, right? So let's start with fistula itself. So when I want to ask the question, can the baby swallow, right? So I'm asking this question, can the baby swallow? And the baby's like, no, I cannot. Well, baby's not going to answer. We're going to see. Yeah, he's not going to swallow. So what's going to happen in not trans. Wow, the fuck I'm saying. Not trans. Tracheoesophageal fistula. Yeah. So TEF, I'm so sorry. So it's tracheoesophageal fistula. Now, such a premature, I think, such a mistake for me to say this as transesophageal. Because I was reading cardiology and I just okay. So tracheoesophageal fistula. What's really happening here is that what is the most common type of TEF is just that we have esophageal atresia and distal TEF, right? We have a fistula and we have atresia, right? Now, what exactly is atresia? Well, when I'm really understanding this word atresia, let me write atresia. Atresia is basically no lumen, okay? It's just lumen is completely absent, okay? It's a congenital absence or just closure of a normal body opening, right? So that's simply atresia. So let me write it here. Atresia is just no lumen, okay? That's simply that's it. We have this lumen, right? This esophagus, and the lumen is closed. So that's basically atresia right there. Okay, so that's atresia for you. So what's really happening here? The thing that is happening here is that we have what happens in this configuration. We have upper esophagus, and it ends blindly, and the lower esophageal connects to the trachea, right, where we breathe, and the food cannot reach the stomach normally, and sometimes the food, instead of going to the stomach, it goes to the lungs, right? So we're going to have some sort of aspirations. Now, embryology, simple. What is the defect? It's simply abnormal partitioning of the foregut, right? Why does the NBME says endoderm abnormality? Because esophageal epithelium is derived from endoderm, right? And because endoderms gives foregut derivation, and then foregut gives you endoderm origin, right? Simple stuff. So that's very important, actually. So endoderm is the important thing right here. We want to highlight that thing, okay? Because very much asked. Okay, clinical presentation. Simply what's really happening. Baby is born. We have first feeding occurs. Immediately the baby is coughing, choking, gagging. There is cyanosis because baby is not able to breathe. Milk is coming back. It's not going to the stomach, right? Why does the baby choke on the first feed? Because milk enters in the mouth, hits the blind esophageal pouch, and has nowhere to go, so it regurgitates back. Now, what's the most important diagnostic test? We just insert the nasogastric tube. Now, the thing with nasogastric tube is that we don't want to insert it too aggressively because we might perforate something. So we do it not so aggressively, gently. And what happens when you insert the NG tube? When we insert the nasogastric tube, if the tube advances, it hits the blind pouch and it cannot pass further. This confirms the diagnosis, right? So we have two things. We have trachea esophageal fistula, this abnormal connection between esophagus and trachea, and then we have choanal atresia. Now, choanal atresia is just your nose are kind of blocked, simply. So TEF, we have problem with swallowing, the child cannot swallow, and choanal atresia is that problem with breathing, the child cannot breathe. Here in choanal atresia, we have usually problem with breathing because children are kind of obligate breathers, right? Now you can ask one more question, that why newborns are obligate breathers? Well, newborns are obligate nasal breathers because their anatomy makes breathing through the mouth very difficult, and they can breathe through their mouth in extreme situation, of course, but during a normal life they really depend upon nose entirely, especially during this first 2 to 4 months of life. Well, the problem I think children have is that they have really huge tongue, right? So tongue really sits in the mouth, and when they open their mouth, the tongue actually kind of stops the airway, right? Other problem is that I think the larynx sits quite high in the neck. So in the newborn, the larynx is, at I think C2, C3, but in the adults, it actually goes downward. So it goes to C4, C6, right? So the high larynx actually places the epiglottis, right? Epiglottis and soft palate very close to each other. So very close to each other, right? They are very close to each other. Now, why this is useful? Because it creates this continuous airway, right? Nose, nasopharynx, epiglottis, soft palate together, right? And then larynx and then trachea, right? So this arrangement actually allows these infants to suck milk and swallow and breathe at the same time with less risk of aspiration. Now, it's a cool thing, I think, right? So mouth is usually occupied, right, when they are drinking the milk. So that's why they are obligate nasal breathers, right? Nasal breathers. So the first topic was simply what is tracheoesophageal fistula. It's just that we have a blind pouching, right? The milk is coming back, right? For example, here you can see the NG tube goes back, right? We have this pouching going on, milk comes in, goes back. The cough happens because the milk is getting expired in the lungs. And what else is happening? Again, NG tube coiling up. That's one of the diagnostic. On the x-ray, we're going to see coiled NG tube in the blind upper pouch. And that's it. That's the topic. That's it. Fistula, TEF fistula, is just that we have this esophagus, and we have this trachea, and then we have this abnormal connection. That's simply TEF, right? Simple stuff. Okay, let's go to the next topic. The next topic is choanal atresia. Now, what's really happening here? What is choanal? What is choanae? Well, choanae are these opening connecting the posterior nasal cavity to the nasopharynx, okay? Now, what happens in atresia? I told you atresia is just no loops, right? No blind pouch. So what happens in this atresia? Basically, choanae fails to open and nose is blocked. And why is this immediately dangerous in newborn? Because newborns are obligate nasal breathers. They strongly prefer breathing because they have huge tongue. And that's how it happens. What's the clinical presentation? Clinically, the baby starts to breastfeed, right? Immediately turns blue. Now, why does the baby turn blue during the feeding? Because mouth is occupied by the breast, cannot breathe through the blocked nose, and then hypoxia. What happens when the baby cries? When the baby cries, mouth opens, air enters, the baby becomes pink again. Now, why does the crying help? Because crying forces mouth to open and it bypasses the blocked nose and restores airflow. Of course, what is the highest yield clinical pattern? Well, cyanosis during the feeding is the very characteristics of choanal atresia. So, cyanosis during feeding, very important thing. What's the next? The next question is, how is it diagnosed? Again, we insert a nasal catheter or an NG tube, and it will not pass through the tube. Sorry, pass through the nose. Simple stuff, right? Let's go to the picture. That's the photo. We have choanal atresia happening. That's the nose, right? These are the choanae. Here, the airway is blocked right here. As you can see, if you put an NG tube, it's not gonna pass ahead and it's gonna coil up and it's gonna maybe come back. Basically, that's the blue baby. We have some little bit of cyanosis happening right there. So that's the topic. What about Charge syndrome? Well, Charge syndrome, first of all, why are we even studying about Charge syndrome? Well, we study about Charge syndrome when we try to study choanal atresia, because choanal atresia is one of the hallmark feature of Charge syndrome, right? If a baby has this atresia happening, especially in both nose, right? Sorry, not nose, in both choanal, right? If you have a bilateral atresia, we want to look into other components of the charge, because we have this pattern happening, right? Now, what exactly is charge? We have coloboma, right? Wow, coloboma. Okay. Now, what exactly? We have a hole in iris. We have a keyhole pupil appearance, right? Now, it's a defect in iris, right? It can be a defect in retina. It can be a defect in optic nerve as well, right? What other thing is that we have heart defect. Well, heart defect, usually it's tetralogy of Fallot. CHA is atresia of choanae, right? It can be unilateral, bilateral. Unilateral is just one side, bi is just on both sides. R is going to be retardation of a growth. Well, we're going to have a growth delay, a developmental delay. Then we have genital abnormalities. Then in these genital abnormalities, we're going to have a micropenis. We can have cryptorchidism, right? We can have hypogonadism, right? And then in the E section, we're going to have ear abnormalities. Now, in the ear abnormalities, we can have this, usually external ear is affected, or maybe we can have some hearing loss as well, right? So let's compare TEF, that is tracheoesophageal fistula, the connection. Then we can compare choanal atresia. Let's compare both of them. The problem with TEF, the fistula, is that you cannot swallow, because everything you swallow goes to the lung. Trigger, usually feeding, causes choking because milk goes to the lungs. Relief, there is no relief, honestly. Obstruction is that we have a blind esophageal pouch, okay? NG tube stops in the esophageal, gonna pile up. Choanal atresia, your choanae are blocked, cannot breathe through the nose. Feeding causes cyanosis. Baby cries, baby opens the mouth, and then the baby becomes pink again, right? Blocked. What's the problem here? The problem is that we have a posterior nose that is blocked, and the NG tube stops in the nose itself. Okay, that's done. Let's talk about CADH, congenital diaphragmatic hernia. Now, one question that comes to my mind I want to ask is, what is hernia? Now, I must answer that because simple term, because it's a very simple term. Hernia is just some sort of how should I say? Hernia is like protrusion, right, of some tissue, of some organ, through some wall, through some opening, okay? And that's it, I think. The organ, or, some sort of organ, some sort of tissue actually penetrates the wall of another, some wall, right? It penetrates through the opening in the wall, and normally it is like contained, right? That's hernia, that's it. And the weakness is due to some sort of congenital defect, okay? I think it can be acquired too, right? Now, mechanically, it's just, it's simple. Your loops of gut goes inside your lung wall, not lung wall, what the fuck I'm saying. Basically, I'm trying to say that hernia is just a protrusion of an organ or a wall through a abnormal opening in the wall, that is close to it. Okay, that's hernia. So embryology, what is the embryological problem here? Well, in CDH, the problem is the failure of formation of pleuroperitoneal membrane. Now they ask this because they want to know what's the problem. So pleuroperitoneal membrane, hole in the diaphragm. Okay, so important stuff right there. Okay, so which side mostly affected? Left side. Why? Because liver protects the right side. So left side defects are far more common. Simple. Pathophysio is that what happens when the diaphragm has a hole, abdominal organs, stomach, bowel, spleen herniate upward into the chest, and then what happens? When these organs are into your chest, the lung is going to get compressed. When the lung is compressed, your pulmonary hypoplasia is going to take place, right? And respiratory distress is going to happen, right? Another question I want to ask is, what exactly is hypoplasia? Well, simply, hypoplasia is just an organ, when an organ develops, but it develops too little, simply because right here, we have a child, and this child has, stomach in his chest wall, right? Not wall, inside the chest cavity. And the lungs are developing in this age, right? And what's going to happen? Basically, this child is not going to have a normal lung volume because stomach's there. So that's why it's hypoplasia. So hypoplasia is just simply I should say little development. Okay, simply it's just little development, right? Well, there are other terms. I mean, agenesis is just organ never forms. What are the things? Hypoplasia is just organ forms, but it's little in size. Atrophy is something else. Atrophy is that organ was normal, but then it shrinks later. Because of some blood supply problem. Okay, that's it. That is atrophy for you. Okay, so we have hypoplasia of lungs, right? Okay, physical examination. What we're gonna see? Of course, we're gonna see some bowel sounds in the chest because bowel is in the chest. What else can be found? Decreased bowel sounds in the abdomen. Okay, bowel sounds in the left chest because left is usually the common side. What the chest X-ray shows: loops of bowel inside the thorax. What if the stem says, stem here means question. What if the question says cystic structure on the left hemithorax? Well, actually, it's right. These are not cyst, they are intestine herniation into the chest. So these are not cystic structure, okay? What is the NG tube clue? Well, NG tube visualized in the left chest on imagining because what is NG tube? NG tube is just nasogastric tube. So this is a tube that goes to your nose, goes to your stomach, goes to your intestines. And now these loops of intestine are actually in your left chest. So we, of course, gonna see this NG tube in your left chest. So that's why. Okay, why it happens? Because stomach herniates upward. The NG tube follows the stomach and to thorax. Of course, simple. So that was congenital CDH. Okay, neonate respiratory distress syndrome. Okay, NRDS. What is NRDS? Well, NRDS is what is the NRDS? Let's build this concept slowly. Well, first of all, it's a hyaline membrane disease. Well, before going ahead, I want to understand what is hyaline right now. Now, hyaline actually it's a pathology term, right? It's just hyaline. Hyaline means some glassy, pink. Homogeneous, very important. Homogeneous material seen on which stain? On H and E stain. Okay. Now we're gonna have pink, smooth, glass-like structureless, and we call it hyaline to describe this kind of appearance. Okay. Now different things can look like hyaline. Like what? Like protein, like collagen, like fibrin. Maybe some debris, right? So whenever you see some glassy image, right, you wanna say you are looking at hyaline membranous disease. Okay, so what is hyaline disease exactly? Well, hyaline disease is basically dead cells and protein in the alveoli, and it forms a hyaline membrane. Okay, so basically dead cells plus some protein, simply. Okay, dead cells and protein. Now they are in the alveoli. Now see, in the alveoli, and it's basically called hyaline membrane, right? Okay, by the way, this neonatal respiratory distress syndrome was also called hyaline membrane disease. So that's why HMD, right? Now, the real problem here is not the membrane itself, okay? The membrane actually is a consequence of surfactant deficiency here. So let's build this disease step by step. So the core concept is that what is the starting point of the NRDS? Well, the core concept is prematurity. The baby is born before the lungs are mature enough. Now, what is the high allele gestation clue here? The baby is born 34 weeks before. The baby is born before 34 weeks. So, and then we have respiratory distress. So, lungs are immature. Now, what's going to happen? The story of surfactant is that, first of all, what are these things? Well, first of all, even before that, let's try to understand where they even come from. What cell produces surfactant? Type 2 pneumocytes. Okay, through what structure surfactants are secreted? Well, they are secreted by lamellar bodies. Now, what is the function of surfactant? What do they do? They reduce surface tension, right? Keeps the alveoli open after each breath. Now, what happens without them? Well, if you don't have surfactant, the alveoli are going to collapse on every breath. And what's the major component of surfactant? This is very important. It's called dipalmitoyl phosphatidylcholine, lecithin. Now, it's actually been asked multiple times, so gonna make it underline. So, cool thing, right? So, dipalmitoyl phosphatidylcholine, lecithin, is very important in surfactant. That's the actual active thing that you need to keep your alveoli open. If you don't have them, your alveoli are gonna collapse every time you breathe. Okay, so let's talk about this ratio. Lecithin is to sphingomyelin, LS ratio. Now, what is LS ratio measure? It measures, I don't want premium. What does it mean? Well, lecithin sphingomyelin LS ratio, actually, what does it measure? It measures fetal lung maturity. Now, what is LS ratio in mature lungs? It is usually more than 2, usually between 2 to 2.4. Now, what is the ratio in NRDS? It's less than 2, because lecithin, the thing that's active component in surfactant, is low because surfactant production is immature, right? Now, what increases the ratio? Because we have increased sphingomyelin, because L is to S, the lecithin is to sphingomyelin ratio, and then we have increasing denominator, and then it lowers the ratio in mature lung, right? Now, you must be thinking, he's talking so much about sphingomyelin. What exactly is sphingomyelin? Because I think, why do you want to know about it? Because this L to S ratio is actually super cool to know. Okay, we're gonna a little bit understand this, okay? Okay, so why the ratio was invented, first of all. The ratio is not a biological, it's not so important. It's just a marker, okay? Let's build the basic of it. The fetus has a problem to solve, first of all. Inside the uterus, right, the lungs are not fully developed, right? Because it's inside the uterus. Lungs are collapsed right now. So what's going to happen? The placenta does that. The placenta is going to be a lung, okay? So fetal lungs are filled with fluid. They're small, they're immature, they're small, right? So they are not exposed to air. So they are like collapsed right now. So the moment the baby is born, the placenta is, it's scratched off, it's removed, and the lungs are actually opened, right? And it happens because of the air, right? So placenta goes goes off, and lungs are on now. So this is the transitional period now, right? So placenta is removed, so I should say off, and lungs are actually open for the first time, so on. Now this period is the transitional period, right? And actually, you should know that this period really doesn't exist. There is no transition period. It happens immediately. That's the thing I'm trying to say. So lung must work immediately. There is no transition period. That's the concept. So if you have transition period, how the hell baby is gonna even breathe, right? So lung should be available to breathe, right? Now the main problem here is that alveoli wanna collapse. They wanna collapse. Now think of alveoli like a wet balloon, right? Now inside each alveoli we have air, and then we have the fluid, right? This is the alveoli I'm making, right? We are looking at alveoli from a superior view. Okay, wait, I'm gonna make it alveoli bigger. So this is a big alveoli, right? And the fluid inside the inner walls. This is an inner wall, right? There is fluid here. Okay, that's a little bit of too much fluid. Okay, so I'm gonna make fluid here. The fluid is inside, okay? So this is the air. So this is alveoli, right? This layer is alveoli membrane, right? So what's gonna happen is that we have this, we have this alveoli. There is water molecule right here. This is water molecule itself, okay? Just imagine with me. Now the water molecule actually is attracted to each other, right? This creates a surface tension. Now this surface tension of each water molecule is gonna pull towards each other. So what's gonna happen is that we have a pulling motion towards each other because the water is inside the membrane. Okay, it's on the inside. We're gonna have this type of pulling motion, and due to this surface tension, the alveolus naturally wanna shrink, right? So this is why it happens, right? So yeah, because the water is present inside the inner wall, the surface tension increases. The water molecules, they are attracted to each other. Now you can ask me, why the water molecules are attracted to each other? Well, we can go deeper and deeper, but I don't want to discuss that. Just want to tell you that this is how it happens, right? I mean, you can Google it, why water molecules are attracted to each other, right? So they're gonna attract to each other. They're gonna collapse the alveoli, and alveoli wanna shrink. And this actually happens in small alveoli, right? They want to collapse. Now the game player, the cool thing, fetus needs an anti-collapse system, an anti-collapse chemical. Now that chemical, that system is surfactant, right? Now it is produced by, we already know where it comes from. It comes from type 2 pneumocytes, right? And what does it do? Well, actually surfactant, it actually decreases this tension that you have, and it stabilizes, prevents the collapse. Now that's cool, right? Without surfactant, the alveoli is gonna collapse. So what is surfactant made up of now? Let's come to the ratio question now. So it is made up of lecithin, right? Lecithin, lecithin. Now what is lecithin, by the way? Lecithin is just lipid, simply. It's just lipid, right? It is lipid, and it's just phospholipid, and like 90% is just lipid, and maybe 10% is protein. Okay, you must be thinking, oh, I'm wasting your time. No, it's very important to know what exactly is lecithin. We are studying so much about. Now it's called what is this weird name? Dipalmitoyl phosphatidylcholine. And this is a star. This molecule actually lowers the surface tension and keeps the alveoli open itself. Okay, so again, what is sphingomyelin doing here? Well, sphingomyelin is another lipid, right? It's another phospholipid, but it does not actually contributes to this surfactant function, this surface tension, this decreasing the surface tension problem. It doesn't do much actually, right? It doesn't do much in this sense. It doesn't do much for the alveoli, right? So the sphingomyelin actually is found in other parts of the body as well, right? Like cell membranes and nerve tissues, in myelin, tissue, just everywhere, right? Then why are we comparing it? Because lecithin changes dramatically and sphingomyelin stays relatively constant, right? So for example, I'm going to talk at 24 weeks. So at 24 weeks, we're gonna have the ratio is gonna be like, okay, lecithin is gonna be 1, sphingomyelin also is gonna be 1. At so the ratio is like 1 to 1, that is 1, right? So these are immature lungs. At 30 week, the lecithin is gonna actually rise up. So lecithin is gonna go up 1.5, and sphingomyelin is still gonna be 1. Okay, so okay. So quite developing. The lungs are getting okay now. Now at the peak at 34 weeks or 35, the lecithin is gonna jump to 2, and sphingomyelin is still gonna be 1, right? So now, as you can see, the ratio is actually, what is the ratio now? The ratio is L upon S. So what's the ratio? 2 upon 1, that is 2. The ratio went up, right? So 2 is the magic number here. Now, why does the lecithin suddenly increase? We can ask this question, no? Because type 2 pneumocytes mature late, right? Why does the lecithin suddenly increase? Because this is how the nature is. Type 2 pneumocytes mature late, and type 1 pneumocytes, these are the thin gaseous exchange tissues, they actually are present from early times, right? So type 2 and type 2 pneumocytes are actually, they develop late because they're kind of complex in nature. It takes time for them to build because they are cuboidal. They have surfactant, production of surfactant work, right? And they replace the damaged type 1 pneumocytes as well. So they are much more complex in nature, and that's why it takes more time for them to grow, right? So they are developed later in the pregnancy. So this is the ratio that is important, right? So that's your question. Why do we measure this? Okay, so let's go into different into into physiology of this in surfactant, right? Okay, so here we have, what is the surfactant deficiency due to the lung? We know that we're gonna have a collapsed lung, right? What's gonna happen? Low surfactant, compliance goes down. Now understand this compliance concept. Let's talk about it. Compliance is just when I'm talking to a guy and I say, hey, can you bring me water? And it means that guy is quite compliant. For example, I need a worker in my coffee shop, and I tell them, hey, can you make this type of coffee faster? And he's like, yeah, I'll do it. And it means the guy is really compliant. And if I tell them that, hey, do this, and he's like, no, I'm not gonna listen to you, I'm not gonna be compliant. So when I say that lung is really compliant, this means we can stretch the lung really easily. It's really stretchable. But when the lung is quite become fibrotic and it's really damaged and it's like a bad lung, it means the compliance has gone down. It's not really elastic. I cannot really pull it outward easily. It's like a bad rubber, So less surfactant, right? So what's the complication of the deficiency of surfactant? So less surfactant leads to less compliance. It's like a shitty lung, and then elastic recoil goes up, right? And when the elastic recoil goes up, the lung collapses more easily, right? Okay, simple stuff. Why does normal surfactant? What does normal surfactant do to compliance? It keeps the alveoli open, keeps the compliance increase, right? Increases the compliance, makes you want to stretch easily, right? Because if we don't have surfactant, the lung is wanna collapse, right? The alveoli wanna collapse because of the water that is present inside the alveolar walls, right? Not inside the walls, in the inner wall, right? Imaging, what I wanna see on the image, we gonna see reticulogranular appearance, also called as ground glass appearance, right? Because it's it's a highly membrane disease. We're gonna see this dead cells and protein, right? And we're gonna see them on HNA. Okay, cool. How can we prevent it? We can prevent it when we give the mother what? Corticosteroids. Cool. Why? Because corticosteroids accelerate fetal lung maturation, promotes the surfactant production. How many doses? We need 2 doses within 24 hours, right? Classic NBM trap. Mother received 1 dose 12 hours ago. What's the next? Give the second dose, right? What gestational age threshold triggers the steroid administration? More or equal to 24 weeks. Okay, we wanna give corticosteroids. Now here I have another question in my mind. The question is that cool distinction one, I think. So, of course, I confused a lot of times between corticosteroids, glucocorticoid, mineralocorticoids, right? Dexamethasone, betamethasone, hydrocortisone, a lot of drugs. They are not identical, but they are quite related to each other, right? So, what are corticosteroids? Corticosteroids are just hormone produced by a adrenal cortex, right? Now we have two types of corticosteroids. We have mineralocorticoids, that's the aldosterone, and then we have glucocorticoids, that's the cortisol itself, right? Aldosterone, salt and water balance, right? And glucocorticoids, the cortisol itself, stress, anti-inflammatory, blah blah blah. Okay, so we want to, why are we giving corticosteroids? First of all, let's build this concept about corticosteroids a little bit. Okay, so we have the synthetic corticosteroids, right? We have hydrocortisone, prednisone, right? Dexamethasone, right? Now dexa, beta, both of them are pure cortisol analogs. Okay, prednisone and methylprednisone are mostly glucocorticoids as well. They are mostly, okay, and hydrocortisone is a mixture of glucocorticoid and mineralocorticoid. It's a mixture. So hydrocortisol covers both of them. So both of the genre of corticoids, right? So betamethasone and dexamethasone are the glucocorticoids. They are also corticoids, okay, corticosteroids. So the terms are not competing, okay? I hope you know that. So which steroid are we giving in an RDS? We are giving betamethasone or dexamethasone. Let me write it. Betamethasone and dexamethasone. Okay, and we are giving them to the mother. Okay, we're not giving them to the child. And why are we giving them at all? Because we have this immature type 2, right? Lateral surfactant, alveolar collapse, and RDS. Now, what is going to happen? Steroid is going to accelerate type 2 pneumocyte maturation. We're going to have a nice surfactant party going on in the lung, okay? So, betamethasone, type 2 pneumocyte maturation, faster, more surfactant, more good, less RDS, right? Why, you can ask me, why are we giving betamethasone and dexamethasone, right? Because the thing is that both of these beta, weird name, but okay, betamethasone and dexamethasone, both of them, they can cross placenta really well. So that's the problem. That's the solution. That's why we are giving them, okay? So just know them, and they are quite long acting in their nature, and they don't have any mineralocorticoid effect. We don't want to mess up the aldosterone signaling pathway, right? So that's why we are giving both of these. So beta and dexa. Just know that. Okay. Okay. So now we know that. Management after birth. Okay. Child is born with this this terrible disease, NRDS. What's gonna happen? What is the NBMA management? Okay. Tactile stimulation. We're gonna do this tactile, right? We're gonna touch him. Tactile means touch. Warm light, oxygen, and exogenous surfactant. Now, why does the exogenous works? Because you are replacing the exact thing what is missing. So surfactant missing, surface tension decreases, alveoli stays open, oxygenation improves. So that's the thing. So comparison, let's compare all the four of the things. We have tracheoesophageal fistula between trachea and esophagus, right? By the way, which one is ahead, which one is anterior, which one is posterior? Now, it's a very common confusion. I used to be really confused before. The answer to this is that trachea is always anterior. Esophagus, the food thing, is always posterior. Now, how would you think that? Okay, first of all, let's, we have skin, right? Then we have thyroid gland, then we have trachea, and then we have esophagus, okay? And then we have this spinal cord, right? And then we have this back skin, the back itself, right? The only thing we want to remember is that food goes behind the air. Air goes in front of the food, right? Now you can ask me or think, why the trachea is in the front? It's a good question. I mean, you want to think about it. Why the nature gave us trachea in the front? Now, think about it each tube, okay? Trachea must remain open always, okay? Right? It must, because you cannot compromise on breathing, right? Trachea must remain open, must resist any type of collapse during inspiration, right? Now, to do this trachea has C-shaped cartilaginous rings, right? So on the cross section, we have this C shape, right? Now, okay, we are looking at trachea here, okay? Let me make a trachea. So this is a trachea right here. What's going to happen here is that we have this anteriorly. So I'm looking at the trachea superiorly right now. Okay, I'm looking at a trachea on a superior view. So this is anterior, this is posterior. Okay, so we have this trachea, and this is the anterior view of the trachea. Okay, that's important to know. So what's going to happen is that we have these cartilaginous rings, and they are actually in a C cartilaginous ring, and this is the reason. This is the reason the trachea doesn't collapse. Okay, so we have this C, and on the posterior wall here we have these muscles, right? And here we have esophageal itself, the food pipe, right? So esophagus must expand and collapse, not collapse itself. It must expand to accommodate the food itself. It must stretch when we are swallowing the food, right? So if it had these rigid C-shaped cartilaginous ring, it would never be able to expand. These cartilaginous ring are solid, right? So food bolus goes inside the food, right? And it's really super tough for your esophageal if it had these cartilaginous ring, right? So swallowing would be really difficult. So that's why your trachea has these cartilages, and your esophagus don't have any cartilages, because that's why esophagus is soft and it's distensible. That's why. Now, why the esophagus is behind? That's a very good question to think about, because I think think about it yourself. Imagine you're swallowing a large chunk of food. Okay, what's gonna happen? The esophagus is gonna expand, right? It's gonna be bigger in size. Now you just ate it, right? Now, where would the expansion happen if it was anteriorly? Imagine where, because where should the expansion happen? It should happen behind here. So whenever you eat a lot of food, the expansion happens posteriorly always here. Okay, we have spinal cord on the posterior, by the way. Okay, so this is a spinal cord, not spinal cord, vertebrates itself. Okay, so the expansion happens on the behind. So why? Because vertebrate column is fixed behind. The trachea has a flexible posterior wall, right? So that's how it really happens. The posterior wall of the trachea is membranous and flexible. This allows the air to move, right? And esophagus actually expands during the swallowing, and it happens posteriorly, right? Now you can ask me, why the posterior tracheal valve is not cartilaginous? I mean, because it has to. Let me think. Why? I think it's because of the esophagus itself. Because a little bit of expansion should happen here as well, right? Now most of the expansion happens posterior, but some of the expansion happens anteriorly as well, right? Because when you're swallowing, the esophageal expands and the posterior wall of the trachea actually moves slightly forward. Okay, so that's the thing. Why? Now I would really think about this question, that if God is so cool, I mean nature is so cool, why and how we have these two things separately, right? Why are they separated? Because originally in the embryo we have one tube, right? We have this primitive foregut, right? We have just one tube. Then what happens? Well, actually a septum develops, right? A septum that divides trachea and esophagus. And this septum is called tracheoesophageal septum. It divides the anterior, that's called trachea, and posterior, which is called esophagus. So that's your question answered. Wow, I think I like to get super distracted on these little topics, but I like to talk about these little topics because these are like holes that you can have in your concepts, and someone can poke at these holes and someone can ask you, tell me what about, and then you will look like a fool that you don't even know about why the nature is like that. Someone can ask you, why the trachea is in the anterior part, or why the esophageal is posterior. Now people do not really ask about these questions why. They will just ask, okay, which is the anterior tube? You will ask, you will say, oh yeah, Mr. Trachea is anteriorly, and you will say, oh, esophagus posteriorly, yeah, Mr. But a good question will be, why is that? And now you know why is that, because food has to be accommodated. Food has to be moved. And to do that, you don't have enough space interiorly. You have skin, you have thyroid. Where are you gonna accommodate? The thyroid is gonna get, I don't know, destroyed. Okay. So by the way, this fistula, TEF fistula, right? This fistula, TEF fistula, actually it happens because when you have this this septum, the septum I talked about, this tracheoesophageal septum that divides the trachea and esophageal, it fails to develop, and then we have this fistula, by the way. Okay, so that's the thing. Okay, so pattern just okay. What's the pattern? Simple. Newborn choking on milk. Well, TEF inserts the NG tube, esophageal fistula, tracheoesophageal fistula. Just put the tube. There's a blind pouch. Newborn, blue during feeding, pink when crying, corneal atresia, obligate nasal breathers. I also answered this. Why the child is obligate nasal breather? Neonatal born with bowel sounds in the left chest. Well, we have some sort of protrusion, and this is called hernia, congenital diaphragmatic hernia, left-sided pleuroperitoneal membrane defect. Cool question. Wanna know why do we call it pleuroperitoneal membrane? Well, to answer that, let's talk about it a little bit. Now, I want to know why it's called, right? Well, to understand this, we want to go back to the embryo a little bit, okay? So in the development, we don't have like chest wall, we don't have abdominal cavity, we don't have like pericardial cavity. We just have one cavity. We just have like one space. And that space is called intraembryonic coelom, I think. So why? Embryonic coelom. So we have this thing, right? Now I want you to imagine there's an embryo, right? Now there's a big cavity, and this big cavity, there's no walls yet, by the way. There's just a big empty space, right? This empty space is called intraembryonic coelom. Now, what nature does is that nature needs these little rooms, these little compartments. So as organ develop, you need these little room. So you need, so I'm gonna make a little cavity here. This is a cavity. So we're gonna have these rooms. We're gonna have an upper compartment. Now this compartment is gonna be for lungs, for heart. And this later is gonna become thorax, right? And then we're gonna have a lower compartment. This is the place for stomach, liver, bowel, intestine, right? And this gonna become abdomen, right? And so a lot of we can think that, hey, how do we build these walls between them, right? So we ask this. That's why this is just a abdominal cavity, right? And let's talk now about upper cavity, the thorax, right? The lung actually invade most of the upper cavity. The lung buds, they grow from these foregut, right? We have this, okay, I'm gonna remove these words, right? We're gonna have these lung, this is the bud, right? We're gonna have a little bit of buds growing, and these lung buds grow from this foregut, right? And then they actually expand into this pleural canal, right? So we have this cavity formation, right? Then we have birds. Then these birds actually, where the birds come from foregut, okay? Okay, now don't ask me where the foregut comes from. So the foregut actually gives birds. Now the birds gives us pleural canal, okay? Now this, okay? So I want you to think like this. We have this is anterior view, right? This is posterior view, okay? We have, here is the heart itself, okay? Now we're gonna have lungs here, and we're gonna have lungs here too, okay? And this is space, okay? So then we have this, we're gonna have some abdominal organs below, okay? So at this point, the thorax and the abdominal are still connected. Here, they are still connected, right? Because lungs are forming, right? Now, this thorax and abdominal are still connected. Now, right now at this moment, we're gonna have two openings in this connection and this valve. So these connections are called pleural cavity and peritoneal cavity, right? So now we enter the pleuroperitoneal membrane. Now let's break this name. Pleuro, wow, Pleuro, pleuro, peritoneum membrane. Let's break this name. Pleuro means pleura, which means lung. So pleura literally means lungs. And peritoneum means peritoneum, right? It's a layer that surrounds the abdominal organs, right? So membrane is just membrane. So pleuroperitoneum membrane is just a membrane between pleural cavity, the lung cavity, and the peritoneal cavity. Simply. Now what's the job? The job is to close this communication. That's the job. So chest, we have chest, right? Then we have pleural cavity. Then we have the opening that is talking to the pleural cavity and the abdomen, right? Peritoneum. And then we have abdomen, right? So the membrane grows and seals this opening, this one. And it's like closing this opening. Now after the closure, the thorax, this part, and the abdomen, this part, is not talking to each other because there is a big ass diaphragm. Now this diaphragm has four parts. Wow, I am like going into embryology. Don't want to go. So the diaphragm develops from some muscles. I don't remember it right now, but this is how the diaphragm is born, right? So clinically, pleuroperitoneal cavity is important because most congenital diaphragmatic problems like hernias happen here at this point. Wow, we went from pleural peritoneum to the embryology, but that's how it works here usually in medicine. Okay, what if this diaphragm fails? We're gonna have hernia, simply. Okay, so that's the pattern right there. Okay, NG tube seen on the left chest, CTH, right? We have hernia because the diaphragm failed to develop, right? Premature, less than 34 weeks. The ratio, less than 2. We know why we have sphingomyelin. We know why the lecithin exists. Mother expecting premature, we give corticosteroids. Which one? We give betamethasone, right? And which one? And we give, and this one. Ooh. And Dexa, right? I think it's Dexa. I hope it's Dexa. Where are you? Okay, leave it. So we give just Dexa and beta, simply. Mother received one steroid 2 hours before. Next step, give the dose immediately. Charge syndrome. C, right? It's going to be important because they can ask. Charge is just colobama. That's the hole in the iris, not in the iris. Problem there in the ophthalmic problems, right? H is going to be heart defects. A is going to be atresia of the choanae, right? Your nose is blocked. R is going to be retardation of the growth, micropenis. Genital abnormalities, the genital abnormality, micropenis. And we're going to have ear abnormalities like problems in hearing, okay? And that is charge, simply. So if you see a question with these things, just think about choanal atresia. So we conclude, I think we conclude neonatal problems, I think, right? Did I? Yeah, I think we do. Right, let me check again. These 4 topics, I think. Part 1, okay. And then we have part 2. Yeah, I forgot. Yeah, we have TTN, BPD, foreign body, pediatric ENT. Let's talk about them as well, right? So in this topic, we have TTN, right? Okay, TTN, BPD, basically is its term versus premature, sudden toddler distress. Oh, foreign body. This little child ate something and it's in the lungs, it's in the trachea. Noisy breather. Why? Let's talk about it. One simply. TTN, BPD. Let's talk one by one. Okay. Okay. Well, these are the photos. We can come back to them if you wanna. So whenever we have these kind of topics, basically we wanna ask, is the baby premature, NRDS or BPD? Is the term newborn. Then we're gonna think about TTN. Wow, sudden distress, foreign body, noisy breather, maybe some sort of vascular ring, maybe adenoid, maybe peritonsillar abscess, maybe some sort of abscess there, right? So what is TTN? I'm saying TTN. What is TTN? TTN is transient tachypnea of newborn. The baby is breathing fast. Why? What is TTN? Delayed clearance of the fetal lung fluid. There is fluid inside the lung, not surfactant deficiency. That distinction is so important, right? If the baby is premature, we can think about NRDS or BPD. If the baby is mature, like 40 or 39 weeks, we have to think about TTN. We have this transient tachypnea of newborn. Why? Because there's some fluid clearance problem. How does the NBME tricks you with TTN? Because the vignette will sound exactly like NRDS, tachypnea, respiratory distress, increased work of breathing. But suddenly, in the question there is 38 weeks, 39 weeks, 40 weeks. That kills the NRDS in the question. That's the differential diagnosis for you. Mechanism, well, fluid in the fetal lung before the lung, right? Fluid is there in the lung, of course. Now, lungs are completely fluid filled before the delivery. Now, how the fluid actually is cleared? One way is that pulmonary lymphatics absorb the fluid. So if your kid has pulmonary lymphatic obstruction, the fluid is not gonna move. Second way is that the birth canal compression. When the child is removed, the chest is actually squeezed during the vaginal delivery. And if the child is not delivered via vaginal delivery, maybe via C-section, we gonna have fluid that's gonna be retained. So fluid is squeezed out because of the compression that is done by the vagina itself. Now, why does the C-section cause TTN? Because no birth canal compression happens. There's no compression. The fluid remains inside. We have tachypnea. Why we have tachypnea? Because we have this fluid there, and then respiration is not happening. So of course it's like a compensatory thing. Now, what is high yield association? Respiratory distress term, that's very important, and recent C-section, that is TTN, transient tachypnea of neonate, right? Of newborn. Okay. Imaging, what are we gonna see on X-ray? We're gonna see fluid within the interlobular fissure. We have to see this thing. What is this thing? This is a fluid. This is a fluid within the fissure of the lung. Okay, so we have this fluid. Sometimes I get tired of speaking. I mean, right now I'm getting tired. What are the fissure? Cool question. I mean, people should know. Fissure is just space separating the lung, right? Residual fetal fluid accumulates there, right? So TTN versus NRDS. Cool thing. TTN is term 40, 39 weeks. Premature is premature. NRDS is premature because low surfactant. Surfactant here is normal. There is low association, C-section, prematurity. On chest X-ray, we're gonna see fluid on the fissure. On TTN, on NRDS, we're gonna see reticular granular lungs or maybe glassy, right? And on the course, it's gonna be self-limited. We don't need to treat it. We here in NRDS, we need to give exogenous surfactant. Okay, so cool thing. What about bronchopulmonary dysplasia? Now, this is one of my favorite topics. Bronchopulmonary dysplasia also happens in a premature baby. So whenever we are thinking about a premature baby, we want to think about NRDS and BPD. That's important. So core concept, chronic fibrotic lung disease. So it's fibrotic. It's like damage, big damage. Why? Because it's a long-term consequence of prematurity and oxygen ventilator therapy. What is happening? Why? Because the premature baby is born with NRDS, needs oxygen. You put the baby on oxygen. Oxygen damages the lung. You're like, wow, how? Oxygen is great for the lung. Well, what's really happening? Well, actually, what does the lung look like, first of all, in BPD? I'm going to answer you everything. How the hell the oxygen is actually damaging the lung? Well, to answer that, we're going to think about why do premature baby need oxygen? Because they have NRDS, okay? I hope you know that. Okay, so we give them oxygen. We start the baby on CPAP, mechanical ventilation, right? Now, you must thinking, oh, oxygen is great for the baby. Yeah, it is great. Oxygen is essential and is toxic as well, right? Now, think of oxygen as like controlled fire, right? Your cells need oxygen because food goes to mitochondria. We have ATP and oxygen consumption, we have energy, right? This is safe only if the oxygen is like really controlled. If we give too much oxygen, what's going to happen is that we're going to have reactive oxygen species, ROS. So let me write that. We're gonna have ROS, reactive oxygen species. Now, what are these, by the way? These are superoxide. What is superoxide? O2 negative. Other thing, hydrogen peroxide, H2O2. Sometimes you're deficient in them, hydroxyl radicals, right? Now these are super unstable. They are like dangerous, because this is how actually macrophages actually kill. Okay, so what they are super duper unstable molecules. They steal electrons from everywhere. They steal electrons from fat. They steal electrons from DNA. They damage everything. Okay, so why are these premature babies super duper vulnerable? Because as adults, we have these antioxidant defenses, right? We call it glutathione peroxidase. We call it superoxide dismutase. Sometimes you are deficient in them, and then we have another disease. But if we don't have these antioxidants, you are gonna get messed up from these ROS species. But babies, these premature babies, are also deficient in these superoxide dismutase, these catalase, these glutathione peroxidase, not just glutathione. So what's going to happen? What cells damaged, right? First of all, this ROH actually damages type 1 pneumocyte, the pneumocyte that's responsible for the absorption and for the reaction for O2 absorption, basically. Right, so these type of pneumocytes are super duper fragile, covers all the alveolar surface, responsible for the gas exchange. So ROS damages, right? Now I told you if the baby is premature, we know that on the prematurity, type 2 pneumocytes are not developed, right? You need time. These type 2 are cuboidal, they are like super complex, and we need time for them to develop. So what's gonna happen? Type 2 is not gonna be developed. So less type 2. Once you have less type 2, after the damage T1 are damaged, we know that T2 are like regenerative for T1, they regenerate T1, right? If we have less T2, are T1 gonna be regenerated? No, that's gonna be a permanent damage, right? So that's why the ROS does it. And mechanical ventilation, by the way, makes it even worse. Ventilators save lives, but this pressure, causes this trauma on the alveoli. It stretches the alveoli too much. Now, if it stretches the trauma, if it stretches the mess, wow, I'm saying bullshit. I'm like tired. Okay, let's do this. If the alveoli is stretched excessively, right, what's gonna happen? It's gonna be overextended. It's gonna be over distressed. Then we're gonna have cell injury, right? I hope this makes sense. Why mechanical ventilation is bad for the baby. So the child is gonna look scared. The lung is gonna look like this. Lung is gonna look fibrotic, right? Abnormally developed, right? Okay, what's gonna happen? What is going to happen? What's the classic scenario? Baby born is 24 weeks, right? Spent a month in NICU, received mechanical ventilation, oxygen. Now months later, still need oxygen. Answer is bronchopulmonary dysplasia. I told you dysplasia. What is dysplasia? I told you earlier. Now, why does oxygen causes lung damage? Because oxygen concentration generates this ROS species, damages the alveoli, pulmonary vessels. Complications. Why does the BPD causes pulmonary hypertension? Wow, cool concept, by the way. Fibrosis happens in some part of the lung, right? Increased pulmonary vascular resistance happens here, right? And then we have pulmonary hypertension, right? Let me just slow down this concept a little bit. So imagine this is the lung, okay? This is one part of the lung. Here is the damaged part of the lung. Here they are blood vessels, here also blood vessels, here also blood vessels. So what's going to happen is that your body is so smart that it actually senses that damaged part of the lung. What's going to happen is that we will have vasoconstriction of this area. these vessels, because your lung want to divert all the blood to different part of the lung now. So this is why vasoconstriction happens when we have damage in the lung. This is the concept of vasoconstriction. Why vasoconstriction happen? Why? So I hope I told you simply. Okay. So fibrosis, increased pulmonary vascular resistance goes up. What is vascular resistance? Vascular resistance is going up because we have vasoconstriction. It's harder for the heart. It's really tough for the right heart to push against this vasoconstricted lung. So what's going to happen? We're going to have pulmonary hypertension. Right ventricle afterload is increasing. What is afterload? Afterload is just the amount of work right ventricle has to do to overcome so that the blood can be easily moved. This column of blood can be easily pushed. That's the afterload, right? If increased afterload means it's really tough for the heart to push the blood, right? So RV hypertrophy is going to happen. Hypertrophy, your right ventricle is going to be super muscular. On NBME ECG clue, RVH give, we have right axis deviation. Super duper easy. Why does the increased pulmonary vascularity on chest ray? It suggests that pulmonary hypertension is happening due to BPD in a child. So if we have a child who was born 25 weeks and he or she has hypertensive lung, and they're not gonna tell us that, oh, child has hypertensive lung. They're just gonna give us right axis deviation, and you're gonna think, weird question, the child is born with right axis deviation? No, the child is born with BPD, dysplasia, and we kept him on this ventilation and oxygen. And the question is mostly gonna ask you like, why this child has right axis deviation? Because they're gonna give you weird options like, he has right ventricle hypertrophy. Well, kind of correct. He has hypertension. Kind of correct. Or they're gonna ask you due to increased oxygen. Also correct. So know that. Okay. Foreign body aspiration. Simple concept. He or she, under 2-year-old toddler, puts everything in their mouth. Acute, sudden onset, not gradual, not infection. Right. What's the most important word in the vignette? It's a sudden, because he eats something, she eats something, and this thing actually goes and stays in the trachea. Right? Child is playing, crawling, eats the peanut, suddenly coughing. Why? Because there's aspiration into the lung. And suddenly the child cannot breathe. So we have respiratory distress. Right? Exam finding. What is the ball valve pattern? Well, the ball valve pattern is that we have obstruction that allows the air to get inside, but the air cannot get out. So we have air trapping going on. Finding is that we have a unilateral hyporesonance. One side appears more expanded. Why? Because the air is able to get in, but air is not able to get out because of the aspired, or because of the foreign body that's inside the lung now. Now, what is the complete obstruction pattern? Air cannot enter distally to blockade. Now, what's going to happen? Air cannot enter distal to the blockade, right? I hope you understand this. What's going to happen? The lung is going to collapse, right? Finding, we have unilateral atelectasis or ipsilateral tracheal shift, right? This is not a tension pneumothorax. If it was a tension pneumothorax, the tracheal shift would be against the atelectasis. I hope I am pronouncing it right. Atelectasis, right? So the lung actually collapses and the trachea shift is towards the atelectasis. So it's not a tension pneumothorax. That's how you kind of differentiate. So finding ipsilateral tracheal shift towards the atelectasis, and we're gonna have a collapsed one lung. Okay, maybe on the left, maybe on the right. Usually it's on the right. Which way does the trachea shift on the atelectasis? Towards the collapse. The trachea shift is ipsilateral. Okay, diagnosis treatment was gonna NBME answer is for the diagnosis is bronchoscopy on fibro-optic examination of the airway. That's a very cool thing. We wanna underline this. We wanna do bronchoscopy. Wow, my pronunciation weird. Why bronchoscopy specifically? Because it both diagnoses and removes the foreign body in the same procedure. It's like ERCP, right? In gastro. Okay, where I'm going. It's like ERCP. So that's it. Allergic rhinitis, okay, lymphogenal carcinoma, tracheomalacia, rapid. So I think I'm gonna continue this thing in the next video. Okay, so I'm gonna take. Okay, bye bye.